Assalamu alaikum. I'm Dr. Syed Anwar Jillani, and we are starting our session on the Clawfoot management by the Ponseti method. I would start by the name of Allah. Bismillahir Rahmanir Rahim. Alhamdulillahi Rabbil Alameen. Ar-Rahmanir Rahim. Maliki Yawmiddin. Iyyaka na'budu wa iyyaka nasta'in. اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين آمين. So I would welcome the panel. Our panel includes Professor Jose Morcuende, Professor Shafique Pirani, Professor Mansoor Ali Khan, Professor Anisuddin Bhatti, Professor Amin Chinoy, Professor Mehtab Pirwani, Professor Monica Nogueira, uh, Dr. Asif Paracha, Dr. Nusrat Rashid, and myself. So I welcome you all. The chair of today's seminar is Professor Amin Chinoy and Professor Mansoor Ali Khan. And I would start with the first talk from Professor Jose Morcuende, and the topic is Ponseti method of clubfoot treatment, a global perspective. In a moment, we'll have
Committee and Dr. Chinoy for the invitation to participate in this meeting. It is for me a great honor and privilege. I would like to talk about Ponseti International Association and how the organization is building a global program to eliminate clubfoot disability. As you might know, clubfoot is a relatively common problem. It happens in about 1 in 1,000 patients, newborns, and the majority of the patients actually are born in Asia. And this makes the treatment sometimes very difficult for the families because of the lack of resources or limited resources and also limited access to care. Therefore, in many countries, clubfoot becomes a disability. And we can see here pictures of adults and children with the deformity. And the truth is that this, in the last few years, have changed thanks to Dr. Ignacio Ponseti. Dr. Ponseti developed the treatment for clubfoot that now bears his name, the Ponseti method. He published his paper, the first paper, in 1963, but unfortunately, the orthopedic community in this country and in all the countries didn't really understood the problem of clubfoot and the treatment. And it was not until he published his book on the treatment of clubfoot that the orthopedic community started learning about the Ponseti method and they start applying the method in their clinics. The method, as you know, is very simple in concept, although is actually complicated and difficult in practice. It consists on gentle manipulations of the foot and then the application of casts. And usually, actually, in our clinic, 90% of the patients require 5 or 6 casts as average, and the foot is fully corrected after about a month and a half. So it's a method that can be applied, as you know, in almost every country, because it doesn't require high technical and expensive treatment. If you look at the literature, there's a lot of papers demonstrating a 95 to 100% correction rate. So almost all the cases, if not all the cases, can be corrected successfully. And now we know that actually this can also happen not just in newborn, but in older age, even up to teenager time. Therefore, the method becomes a public health intervention, really. In the United States, there was a study showing a decline in the number of surgeries for clubfoot of an 85% reduction. And so what that means is that it started in 2000, which was the time that the first course was in actually 1999. So as people were learning in the United States, the number of surgeries came down dramatically. The problem is not everybody, but I would say many people don't follow strictly the method. And there's a lot of clinical variation and results, but when you analyze these studies, is because there's deviations from the manipulation, the casting, the tenotomy, the use of the bar, the type of brace, and so forth, and how you treat relapses. So the method is actually very successful, and if it's followed as the protocol that are defined, then the results are excellent. But if you change or you don't perform the casting technique properly or you don't use the brace as is indicated, then the results will come down. And unfortunately, that has implications on the patients and the families, make it more expensive and also more frustrating. And you can see here some cases with overlapping of the toes, overcorrection in the midfoot, problem with the skin in the back, rocker bottom deformity produced by the casting technique, bending of the tibia, and then what we call complex clawfoot with swelling, inflammation, and skin problems that are only due to casting technique issues. It's not the foot problem, is how do you manage the foot. And so this is very, very important, because when one is thinking about doing the casting technique and treating patients with clawfoot, you need to strictly use the method as is being prescribed and perform the casting technique as properly as possible. Unfortunately, the treatment is not follow up as it should be. And in this study that we published, looking at the membership from PORSNA, the Pediatric Orthopedic Society of North America, and you can see here that only 34% of the practitioners recommend the brace until 4, and it's indicated to use until 4 or 5. And they have a very high rate of relapses. The treatment of relapses is very simple. You do casting again to correct the deformity, and then you perform an anterior tendon transfer to maintain the correction after the age of 4 or 5. But half of the people don't do casting before, and because of that, then they have to do surgical releases. And we know that the long-term effects of surgical releases are very devastating for the patients. In a study that is about to be published, we look at the databases of the children's hospitals in this country, and in black you can see the decrease nationally from 2000, when the method was introduced, 1999 to 2000 to 2012, and in black is the first year of life, so there's a 92% reduction. And this is hard data. This is data from the hospitals that are submitted to this national database. But you can see here that the number of surgeries after the first year of life, means usually relapses or no full corrections, are the same of the last almost 20 years. So what that means is that, and it should be that way, what that means is that if you don't practice the method and you do the proper casting technique and you don't follow the protocols for bracing, the need for surgeries are there, but the implications in the long term are to have a big impact on the life of these patients with stiffness and pain, as is being shown in some papers. And the other issue is that surgeries are expensive, and especially in countries, developing countries, the possibility of having surgery is very limited for many families. In the United States alone, in these 15 years, there was 170 million more dollars used just because the doctors didn't follow the protocols according to the required treatment. Because we were seeing this, and because we wanted to help doctors to learn, like it happened in Pakistan, as we will discuss here in a minute, on September 27, 2006, the University of Iowa and the Board of Regents of the state of Iowa established Ponseti International, which you might be familiar with. Ponseti International is an organization with the vision of a world free of clawfoot disability. By applying the Ponseti method early, one can decrease the number of patients that will end up with like these patients in the picture. And so the Ponseti method is actually not just a casting technique. The Ponseti method is a public health intervention. And I think this is very important because it changes the context of how to think about the Ponseti method in a public health context. The organization now has about 1,000 health professionals over more than 100 countries now. Is a non-profit organization, so it's all supported by private donations and grants, and is overseen by external advisory board established here at the university. And what is important is that the World Health Organization recognized Clawfoot as one of the most important children disability issues. And in this report, actually, they highlight the Uganda project by Dr. Pirani and collaborators because of the successful treatment development of this program. But this can be done in any other country. Now, when you think about public health and globally, the training approach that we are familiar with in orthopedics, training the residents or training of doctors, when you use the public health approach, then it changes the way you have to be thinking about because it has more implications. The technique is the intervention, but that will have a public health implication. And so the key here, when we started with these projects and these programs, is that you have to scale up a proven innovation, in this case the Ponseti method, and so there are Ponseti clinics to reach all in every country, in every corner of the world. Now, there's very important core values for this program. And number one is the high quality with rigorous adherence to the Ponseti method. If you don't do the Ponseti method properly, it doesn't have the impact that it can be. Second is equity. Every single child, no matter if you go to private practice or go to a public hospital, to a small clinic, every single child in every country has the right to be treated properly. Now, the program has to be run by the doctors in the program with the help PIA, as you are familiar with the Pakistan program, which is one of the most successful in the world, actually. And a way to do that is to integrate the Ponseti method into the healthcare system. So it's just another treatment that is performed and not requiring external funding for the treatment, as is happening with some other NGOs that are providing support for Clawfoot treatment in other countries. And when you use these core values, then the Ponseti method becomes public health intervention in every hospital that is required for treatment of Clawfoot. And we developed this Clawfoot care pathway with the input from Pakistan as well as Nigeria and Peru. And every single child has to be identified. It has to be referred to the clinic that it does the Ponseti method properly. The technique has to be perfected to allow correction, and the patient has to be followed up until the age of 4 or 5 at least, when they finish the bracing and the feet is flexible, and usually relapses after that age are very rare. Because of that, we developed the concept of the pyramid, in which the national resources are the professional societies, the training institutions, the regional national health systems, with also the media for awareness. The training programs for not just the doctors, also for local health administrators and also community for early diagnosis. And then this require that the clinical resources, you need the providers and staff to be trained, and also you need the facilities and supplies to perform the treatment. And you also need to educate the parents with respect to how the treatment happened and what are the implications and so forth. We are working in PIA with 50 or more organizations now, including Pakistan. And with the help of the group in Pakistan, the clinical guidelines for the Ponseti treatment were published in October 2014, which are very, very helpful. And if there are actually supported and introduced into the healthcare system, then become the treatment for Clawfoot in the country. And I think this is happening in Pakistan, as I understand. It's important to record the patients, to have the records, and that we developed the International Clawfoot Registry that is being very successful and used by many people. Right now, there's 105 countries, people using. There's 1,250 active users, and up to 2 weeks ago, there was already over 100,000 patients included into the registry. So it's becoming a very powerful, not only for medical records, but also for research. And I believe that in Pakistan, you are using it for research purposes. It's also important to raise awareness in the population, because many times people don't know anything about Clawfoot, and the families become very aware about the possibility. So on June 3rd, which coincides with Dr. Ponseti's birthday, we established what is called the World Clawfoot Day. And I'm very, and I know that in Pakistan, this is a very important day, and it's wonderful to see how the people get involved and spread the word about the treatment and how successful it is. All of this was possible because of a grant provided by the United States Agency for International Development. And as I said before, the 3 countries in the 3 continents were Peru, Nigeria, and Pakistan. And I can tell you that Pakistan is ahead of the game. Right now is one of the best of the programs in the world with respect to Clawfoot, if not the best. And this is something really important, because many of you are involved in this program, and is very successful, I know. So I would like to say congratulations, because this is very important, and the families in Pakistan now have a much better, and the kids with Clawfoot has a much better outlook for their lives than it used to be before. These are some data from the program, different clinics. Pakistan has more clinics now. This is not updated up to now, and so it's wonderful to see the spread of the clinics, so the patients don't need to all go to Islamabad or Karachi for treatment. They can stay relatively local, which it makes much easier for the families to go back and forth for the casting and follow-ups and so forth. The second issue that we wanted to also tackle, it was the need for the braces for maintaining the correction. And the World Organization, what they did a report on the priority assisted product devices. So what are things that are very important because they help? Clawfoot was one of them. And I think this is very important. And unfortunately, braces are difficult to use if they are not comfortable. Many local braces doesn't provide good quality brace, and then the families will not use it, and the relapses will go very high. So with a lot of partners, including the College of Engineering, the Research Foundation, the Entrepreneur Center, and the College of Public Health, and organizations and companies outside the university, we developed what might be familiar for you. We call the Iowa Brace, and established Clawfoot Solution, which is a non-profit company here in Iowa that produces and distributes braces at cost, essentially. It's been very well received. Right now, there's about more than 95,000 braces in kids all over the world, and so far it's 78 countries of doctors and patients that are using the brace. And I know that in many places they recycle, and one brace can be used 2 or 3 or 4, even 4 or 5 times. So we are really happy. And just to let you know, it's a non-profit company, so we provide the company provides the braces at cost for the country. So if anybody's interested, you might want to talk to Dr. Chinoy or Dr. Badi, and they can help you to for you to get the braces in your clinic. And one very exciting development, and I hope that we can talk about this some point with your program, is that Rotary International established the Rotarian Action Group for Clawfoot. This is a group only dedicated to Clawfoot within Rotary. There's about 20 of these Rotarian action groups, including malaria, water sanitation, so forth, and it's the only one in children and maternal health. So this is a program that is gaining a lot of steam recently. We started about 6 years ago, and in the last 4 years, there's been a lot of interest and a lot of activity on Clawfoot. And of the 6 focus areas for Rotary, which is health, peace, and so forth, Clawfoot is one, as you can see here on all the Rotarian action groups. So this is a very important development that is now growing, and we hope that with the help of Rotary, we could develop programs in pretty much every country, because Rotary is present in almost every country globally. So far, we have obtained grants for Brazil, Bolivia, Colombia, Mexico, and Dominican Republic of quite a bit substantial amount of money. And then Argentina, Chile, and Central America will be happening as COVID allows over the next 2 years. And the goal is to expand this to as many countries as possible. So this is, I would say, one of the most exciting developments lately, because it can allow now the funding for developing the programs in the places, in the different countries, and helping to integrate Ponseti within the healthcare system. So I think now we are in a situation in which, the same way that polio was accomplished pretty much the eradication today, I think the Ponseti method can also eradicate the Clawfoot disability associated when the treatment is not performed properly or it's not performed at all. So this is really exciting, and I hope that the group in Pakistan can continue developing the program, and I would say that this is, I would say, one of the most interesting and more exciting programs that in public health today globally. And that was Dr. Ponseti gift to the world. Thank you very much.
Around the world, and especially from Pakistan, the way you have and the Ponseti International helped Pakistan in the fight against Clawfoot. So just a slight change in our. So we have Professor Shafique Pirani live, and we would like to listen to him for his next talk.
Hello, everybody. My apologies for the technical problem. I should share my screen. Let me see if I can do that. As I'm sharing, may I say thank you so much for the invitation. Let's see. This is an unfamiliar situation to me. Can I share my screen, or am I supposed to share screen? There we go. How does that come up?
Just sending you.
Share screen. Okay, there we go.
Just a moment. Okay. We still cannot.
Oh, Hang on a second. There we go.
Do you have?
It's coming, I think. I guess the slides that I sent over didn't come over. Can you see my screen?
We're not unable to see your screen at the moment.
They can see me, but I'm trying to see my screen. Share, let's try again. Share screen. Window. Microsoft PowerPoint. Share. I'm having trouble here trying to organize the sharing of the screen. There we go. Are you able to see this at all?
Not yet.
Not yet.
Not yet. Yes.
I am having trouble. I don't know how to use this program. If I press share screen, and I then try and share the screen, and then I share my PowerPoint Microsoft window, it doesn't do anything. I do apologize. Is my presentation not available? It is not working when the one that I sent?
It is. It's working, but it's not. Your voice is not. In line with the.
I see. Maybe somebody can help me technically while somebody else can talk, or what should I do?
I think we can move on to the talk by Monica because okay, we'll move on to the next talk by Professor Mansoor Ali Khan, third talk of the day, and we can jump back to Professor Shafique Pirani's talk when the technical faults have been adjusted. The third talk, please.
Academic Clinic, how we started and where we are today over the last 10 years. The history of club feet treatment is known to all of us, so I will not just repeat that. Few slides to remind us that evidence dates back to the time of the Egyptian pharaohs. Very exotic treatments have been described for this, and it has been considered to be like torture instruments which were used in the past. Fortunately, we have passed on from braces to CPM machines. All have been tried without success. And Robert Jones used this particularly horrifying looking the Thomas wrench, in which he broke basically all the bones of the midfoot to correct the foot. This is still lying in some medical museums. I've seen one in the Iowa University Museum. These are people of great fame who had great contributions in developing the treatment of clubfoot. Hiram Kite is known basically for Kite's error in his casting technique rather than his great contribution, which is unfortunate. But Kite's angle, for example, in the x-rays is after his name. It was Ponseti who corrected Kite's error by moving the thumb just 1 centimeter from the cuboid to the head of the talus to produce great amount of correction. And this is the error which Kite made, and it's still called as Kite's error. Ponseti corrected this. Now, Ponseti did not invent manipulation in casting. He refined the process of treating club feet with casting at the University of Iowa, and this is detailed in great detail in very beautiful fashion in the Red Book, as it's called, the Ponseti Management, as he wrote initially. He's got many editions now available in many languages. Clubfoot treatment at Indus prior to 2011, we were basically practicing surgical treatment. It's embarrassing to say that now. In few infants, we're using our understanding of Ponseti method. I will emphasize the word using our understanding of Ponseti method because we were learning through videos and books. And this is actually published paper on the surgical treatment of clubfoot by me and my colleague, Dr. Amin Chinoy. And this is how much our interest in surgical treatment of clubfoot was, that we were actually focusing on it a lot. And the number of dedicated clubfoot clinics in Pakistan before 2011 was 0. Very embarrassing. The start of Ponseti method in Pakistan was basically on a self-help basis. Number of orthopedic surgeons under banner of Pakistan Orthopedic Association started workshops all over Pakistan to teach this method. But again, as I will emphasize, it was based on the impression created on books and videos, which can never be the same thing. We used to practice Ponseti method as we knew at our outpatient clinics. Clubfoot patients unfortunately got crowded out of our clinics by other more pressing serious emergency cases. And the numbers, as we noticed before 2011, they were starting to dwindle, got less and less over a period of time. The Pehla Qadam clinic origin was donor driven. We had a friend, a donor in the USA who had pushed us for several years to start this clinic. Initially at Indus Hospital in 2007, when we started, there was not enough manpower. When we had enough of a team, we decided, yes, we'll take him up on it. I spoke to him. And then with the help of our head of research at the research center, a grant was written, which was focusing on a programmatic approach, not just a casting approach, which was quite an unusual thing. And I sent it to him. He then forwarded to Ponseti International and for review. And they liked it very much. And they agreed to support us, which was a huge surprise to me, why they would be interested in Pakistan. And this is how I ended up in the University of Iowa doing my fellowship on clubfoot treatment. This is Professor Jose Morcuende, who is in Urdu, as we say, the Janashin of Professor Ponseti, the heir of Professor Ponseti. Now, the first clinic formally opened in August 2011, but we started to work on a Ponseti clinic in earlier than that. We developed a whole toolkit. This is a huge contribution by our research center, from developing the logo to developing instruction booklets for the healthcare workers, and focusing on the Clubfoot database registry forms, some of which were taken from the International Clubfoot Network database, and some which were for our own medical records. All data was entered into the Iowa Clubfoot data registry, and along with photographs of patients. We used to take photographs from 3 angles, and these were all stored in the Clubfoot database. This is a Mitchell brace, which I was fortunate enough to bring back about 100 with me when I was there for my fellowship. These were a donation. We used them so many times, we would recycle them over 4, 5, 6 patients until they basically broke. But they proved a great help, because we were providing braces in addition to casting treatment, which was not available in most centers worldwide. When those braces broke, through a fortunate meeting with Michael Steenbeek, he guided us to his book, and we downloaded it, and we found that the patterns of all the Steenbeek braces are there. I looked for an orthotist, and me and Dr. Amin sat with him, and we explained to him what we wanted. And this is how the patterns were given to him, and he started having these braces made in Pakistan. Further visits to University of Iowa took place. This is Professor Tom Cook, a central figure in Ponseti International. We also have Dr. Dumna Samad, who's a head of research center, Dr. Hamida Hussain, who is a PhD in health economics. And basically, this is the donor family. These are the people who drove the force behind the starting of Pehla Qadam, and we owe them a lot. Pakistan owes them a lot. We are fortunate to have visits by Dr. Jose Morcuende and Dr. Shafique Pirani. They taught us actually hands-on in our clinics, which was a luxury most of us could not even dream of. Professor Morcuende visited Jinnah Hospital to have a look at their clinic. This is Dr. Anis Bhatti, Professor Ghulam Mehboob. These are the people who set it up in Jinnah Hospital. This was the second real full-fledged clinic in Pakistan for clubfoot. A huge amount of credit for them to start that in the public sector. Now, I'll just give you an idea that we started the clinic once a week with children aged up to 6 months. Only CTEV, which is congenital talipes, no syndromic feet, no myelodysplastic. The number of patients grew so much that we rapidly extended to 1-year-olds and then to 2 clinics a week. Now we treat CTEV, syndromic feet, myelodysplastic, and children up to 8 years of age. Children older than 8 years go to our regular clinics, but they're also casted. we try to operate as less as possible now. We do up to 40 patients casting per clinic twice a week. So that's a huge number of patients which we are doing. We were very, very fortunate to be invited to participate, me and Professor Amin Chinoy, as well as Professor Anis Bhatti, in developing the worldwide clinical guidelines for the Ponseti treatment of clubfoot. We were there along with colleagues from Nigeria, Chile, USA, which is Professor Morcuende, Canada, Professor Pirani, and from Brazil, Professor Monica Nogueira. So these people sat with us, we sat with them, we gave our input, and this was a very mammoth task in the making. And this is now accepted across many countries worldwide. I was invited to speak at the American Academy of Orthopedic Surgeons, a rare distinction. They don't invite many people. This was the president's breakfast, and I represented Pakistan on the economic cost of treatment of Ponseti treatment versus surgical treatment. It was a huge success. I owe all of this to Professor Morcuende, as he recommended that I be invited to speak. We were fortunately awarded a USAID grant shared between Indus Hospital and University of Iowa for teaching and training. This grant allowed us to initially train 40 orthopedic surgeons. The sites were Indus Hospital, JPMC, and LUMS in Jamshoro. 50 more were trained as part of a second phase. Now there are more than 90 clubfoot clinics operational across Pakistan. And just remember, 10 years ago, there were none. This was a proud moment for us, our first graduating class. Children who'd completed 4 years of treatment were passed out, basically, given certificates, goodie bags, and a little bit of a show to encourage them onwards and their parents for the patients they had shown. The child circle in red is our index patient, patient number 1. He was the first patient we started to treat. Now, this celebration is every year in December. It's gotten bigger every year, and it actually became like a party for the kids. They don't like to listen to speeches. This was the idea by Dr. Lubna from our research center. Kids like to be entertained. So we got bouncing castles and cotton candy and just things to keep the kids busy while the speeches were taking place. I think it worked quite well. The COVID pandemic had a major impact on all services worldwide. Our Pehla Qadam was also shut down, along with all non-emergency services for several months from March to August 2020. This was a big blow to our service, as a lot of kids got left behind. There were many problems in our patients, mainly recurrences, but we caught up with most of them. We dealt with them, recasted them, gave them braces again afterwards. And most of the patients are now have had their problems sorted out. 10 years of Pehla Qadam. We had a celebration celebrating 10 years of Pehla Qadam in Karachi. This was a sort of smaller celebration because the area available at our hospital because of expansion and construction is now very little. So we kept it low key, but we were very happy to have 10 years of service provided to clubfoot patients. We were fortunate to have a birthday cake, and I think it's a very nice cake which says "Our rising stars and never give up." That's very important. We just don't party. We have publications as well, and just not going to read all of them. These are just the number of publications we have already had published so far in indexed international publications, and more are underway. Current sites across Indus Hospital and Health Network, there are 5 Pehla Qadam sites, 2,280 patients enrolled with 3,448 feet in Karachi, Badin, Kashmir, Muzaffargarh, and Lahore. We hope to add more sites in the future. So treatment is brought to the patients. They don't have to go to get the treatment. This was, again, a very proud moment for us. This was the first graduating class of Pehla Qadam patients in Muzaffargarh, and a small class to start with because they're just building up their hospital. They just moved into a very nice 250-bed expansion, and it's a beautiful hospital. If any of you have the chance to see it, please go and have a look at it. You'll be very surprised what a good job has been done there. Now, 10 years of Pehla Qadam, just to summarize, it's been a long and at times difficult journey. We have met the most amazing kids and their parents. Fortunate to have worked with legends like Jose Morcuende, Shafique, Pirani, Monica Nogueira, and Anis Bhatti, our very own. We did help change the direction of clubfoot care in Pakistan from primarily surgical to the correct non-operative casting treatment. Big privilege to be part of that. So our aim always has been no untreated clubfoot. And thank you very much for listening to me. Thank you.
Hello. अब आ गई? Okay. Okay, sorry. So I was mute once again. Thank you, Professor Mansoor. It has been an immense pleasure seeing the Pelagadam Clinic in leaps and bounds, and very encouraged to be a part of this program. So I will try and play the talk by Professor Shafique Pirani on the principles of CTEV management. So here we go. Let's see. sorry for the technical fault again. So we are still unable to play Professor Shafique Pirani's talk. So we'll move on to the talk by Monica Nogueira due to her lag in the time in Brazil. So we'll move on to the next talk by Monica Nogueira.
I'm going to talk about syndromic and myelodysplastic Clawfoot, an algorithm-based treatment. And I have no disclosures. The most important thing is not to produce a complex foot. Some of the arthrogrypotic feet are very rigid, and they can start with a deep plantar crease, or they can be innocent, like an idiopathic clubfoot, and then any manipulations could be acquiring these big, deep plantar creases. So you have to change your way of doing the cast. When you start seeing that lateral border, you have to stop abduction, because that means that you're separating the hind foot from the forefoot. And you have to go back, stretch the plantar fascia again, and make sure that the foot is abducting as a whole piece. And then you may not abduct as much as you do in an idiopathic clubfoot, but you have to aim for the total correction of the foot, total talar coverage, and no varus in the hind foot. So the correction maneuver should stretch the plantar fascia to correct the cavus. This is the most important maneuver. And you place your both thumbs in the plantar surface of the foot and stretch, gaining length and maintaining that length. And early tenotomy does not help very much, because you lose the stretch from the continuity of the plantar fascia and the Achilles tendon. So those are hands of Dr. Ponseti and Dr. Morcuende doing this complex maneuver. And you can see the lateral crease on the second picture on your left side of your screen. Molding is crucial in these difficult club feet. So you have to have long leg casts, very well molded popliteal fossa, because otherwise you create a procurvatum deformity. And well-molded forefoot with plantar support. The plantar support should reach all the tools, and they have to be good support. They have to be free in the dorsal part, but not beyond the root of the toes. And the retrocalcaneal molding, as you see here. No bad casts as these ones on the right side of your screen, like a tube. So you create deformities, and you worse the deformities, make the deformities worse. So here's well illustrated with these nice drawings from Dr. Javier Doni from Sevilla, Spain, how you can create the procurvatum of the tibia on a very tight posterior structures like this one, this retroglypotic foot. So if you left some space, the tibia will just accommodate to the position and will have this procurvatum. So you have to tell the parents that tools must not move inside. So you see, to start with, when I saw this cast with the whole foot in, you can see the dorsal part of the foot here. So that means that the molding is completely lost. And then it's not a surprise that you have a complex foot after that you struggle to stretch the plantar fascia here. And at the end of the day, family sent this picture, and you can see that the toes are inside. So they have slipped in the cast. So you have to change the cast, if possible, as soon as possible, or if you can't, you should advise family to take the cast off. If you have skin lesions, like if you left this cast with the toes in, that means that the dorsal part will be crushing to the cast surface on the dorsal part of the foot, and you have this kind of lesions, skin lesions. Contrary to a lot of authors that recommend stop the correction and take care of the skin, these rigid feet, we had good results at continuing to cast, changing the cast more often, taking care of the skin lesion, but not allowing this to open with the plantar strength of the deformity. So you avoid this, protecting and continuing to correct the foot and improving the pressure in the dorsal. It has to be very well molded and controlled with every 2 days cast or something like that. So one good tip to avoid problems is to pay attention on the vascular part, especially on the myelomeningocele babies, because if you don't pay attention and you take too long to change the cast, while you took the cast, there's a phenomenon called vasoplegia, and the foot gets very swollen. And then it's very easy to do new skin lesions on your next molding. So you have to avoid that. So you have to change the cast, do the hygiene quite fast, and then apply the next cast just after that. Because you can have very serious lesions, as you're saying here, and those are very scary, and it's nice to remember that anyone can have them if they don't pay very much attention to detail on these moldings. Especially myelomeningocele babies, the alarm signs won't be there. So you can have these scary surprises. The brace. So the brace is in the same abduction as the last cast. If the last cast is at 30 degrees, that's the position that you have to put on your brace. After some weeks, the foot will gain flexibility, and then you can progress to 70 degrees. And those feet will need all the 70 degrees of stretch to avoid recurrences. And if the braces are too soft or any flexibility of the bar or something like that, they will not hold the correction. So if they are quite more firm, as you see here, and you see this is a plantigrade foot, but there's not a lot of dorsiflexion, but after 3 months in 23 hours a day, you see that you gain good dorsiflexion because the kid will be stretching every time he kicks and extends the knee, and will have the Achilles and all the posterior structures stretched. Here, you show that myelomeningocele babies will not tolerate sometimes short shoes. Why? Because they have bony fragility, and sometimes they can have fractures when they're crawling on the ground or even doing some movement with the legs. And so it's a good idea to have AFOs connected to a bar, and that is the only real good indication for AFOs together with a bar. And where they, when they grow up and they get to a nighttime bracing with a bar, you can, during daytime, disconnect, and they have the AFOs without having to try for 2 different braces, because sometimes those are expensive and the kid will not use it very well. If we don't pay attention to this, social conditions of families, the bracing protocol may not be perfect. So this is a good tip to avoid fractures and to allow for a good bracing molding for daytime and nighttime with the bar. Here are the fractures that could be horrible, as you see, like tumors. So when you do tenotomy and you had a correction, sometimes it's a tibial osteotomy, so you have to pay attention to this and this bone fragility. So as we already mentioned, myelomeningocele challenging in multiple clinical considerations, lack of sensitivity, propensity of ulcers, very well molded cast is needed with total contact principle. And the muscle imbalance will be the responsible for all the relapses. So our case series presented in SICO last year, we had 43 children, 64 feet, previous treated 37%. Most of them were high lumbar level, and the others distributed as shown. And the age of 2 years, 7 months in average, and follow-up at 3 years and 5 months. The technique was exactly the Ponseti method in detail with elevation of first rate and some complex maneuver if needed. And the abduction braced the protocol 23 hours a day, 3 months, and then nighttime only until 4 years of age, plus AFO or higher brace if needed. So in the 3 children, the Ponseti treatment treated also the infected pressure sores, and while correcting the same time. So the principle of total contact cast. And then 4 children abandoned and went to posterior medial releases. We also presented in SICO our meta-analysis of the myelomeningocele in relation to the studies in the literature. We selected these 6 studies from 763 and a total of 119 patients. And you see that you had initial correction of 93%, as shown as this forest plots here, and compared to our case series 43 in 64 feet, 94% of correction, final correction 71%, and 3.9 years of follow-up in the meta-analysis study. In our study, we also had a good final correction of 82 with 3.5 years of follow-up. The relapse rate was 54 at the meta-analysis studies. In our studies, our series is 56%, complications 42%, and when they put together the relapses as complications, the definition of complication is not quite precise. We had skin complications or fractures in 19% of our cases. So in our hypothesis, as we commented, the feet are very rigid. There's a lot of comorbidities. Tenotomy is in the most feet, usually complex feet, and relapse is the rule. So presented always in SICO this year, Budapest, from the office. We had 23 children in 43 feet, where previous treatment 36%. Most of them were amyoplasia, and the initial age on average was 1.5 years. The number of casts was 4. Tenotomy 76%. The abduction brace, the protocol didn't change. Initial correction was high, as we show 95%. Just 1 not corrected, and the girl that 1 year, 4 months, 5 relapses, and went to posterior medial release. 1 unfortunately died from West syndrome. 74% relapsed, all treated with more casts, and 3 patients had anterior tip transfer. The follow-up was 5 years at average. So comparing the meta-analysis that we also did and presented also, compared to our case series, we had initial correction at 92% in the meta-analysis, and in our series 95%. The final correction, depending on the follow-up, 73% and 74% in our study, but we have more follow-up, 5 years, I guess, 3 years. And the relapse rate 30% with 3 years follow-up, and 74% of the arthro kids in 5 years follow-up. So meaning that if you wait more, you have more relapses. So compare myelo and arthro very good initial correction. Arthro has more relapses, and it's difficult to maintain correction, and you have more tenotomies on the arthro than myelos. Complications then shown here, hematomas, ulcers, rock bottom, fractures, allergies, gas slippage, all types of skin problems, tibial fracture, as we show here, and 2 complex feet. And the arthro-procurvatum of the tibia was the most important, and complex feet, and fracture in the brace. Comparing the relapses, they were higher in the arthro, and they were treated with new casts in 56% in myelo and 70% in the arthro. And we had 21% of posterior medial releases and 11% of posterior medial releases in the arthro. So these are examples. Myelo, 3.5 years. After 1 month, 4 casts and tenotomy. He's wearing the short shoes, foot abduction brace because he's a grown-up with good correction. Here's a walking girl, lower lumbar level. You can see that she had internal rotation, important internal rotation, and she had tibial osteotomy indicated, and we were waiting for that. We did 3 casts, and she corrected, as you can see, that the soft tissue had a very important role in this deformity. Lower lumbar level, 3 years, 8 months, and she is after 4 casts, and her reciprocating great ptosis and big long brace. Ulcers treated with Ponseti, as we commented already. Ultra-hypotic distal, this boy treated with 6 casts, very rigid foot, and here he is after 11 years of follow-up, maintaining the correction after 4 relapses treated with Ponseti and anterior tip transfer. So this kid is a syndromic hyperglycotic, very complicated one, and here it's corrected and using his extension braces. Another one with a big deformity and high gromas, as you can see here, and here's after correction, and here's using his AFOs to walk around for the first time. So in the algorithm that we recall from Ponseti International Barcelona 2014, we divided the myelodysplasia picture in 3 phases: assessment, where the most important thing is the controlling of clinical conditions that will prevent you to have good results in Ponseti method if you don't pay attention to hydrocephaly, cerebral hypertension, problems with liquoric fistula or seizures. So you have to control that first, and then you start the Ponseti method. Treatment, you have to watch out for signs of complex or not progressing in the correction. So if you have you have to redo your technique, ask for help, so you don't keep doing the cast and insisting on the same error. So it's very important to acknowledge for the progression of correction. And the follow-up, the braces should be customized, as we commented, this AFOs with bar, the adductor band protecting the hips, abduction most times, to avoid fractures and consider recasting. Tenotomy not always necessary, but if that can be necessary, and sometimes even tenectomies or resection of a piece of the tendon, especially on the lower levels, to avoid recurrences. Thank you for your attention, and thanks for inviting me. It's a pleasure to be in Pakistan again.
Monica, good to have you in Pakistan. So we'll move on to our next talk from Professor Anisuddin Bhatti. We are still trying to figure out a way to get Professor Shafique Pirani on our line. So we move on to our next talk from Professor Anis Bhatti.
Bismillahirrahmanirrahim. This is Dr. Bhatti from Karachi presenting Pakistan Clawfoot Registry Clawfoot Disability Program, Disability Prevention Program and its role. This Clawfoot Registry was initiated and registered with International Clawfoot Registry in November 2011 as Pehla Kadam program owned by Indus Hospital. And in 2013, this Pehla Kadam Registry was given a national status by renaming as the Pakistan Clawfoot Program Portal. On the same day, Ponseti International Pakistan will become the global partner to the Ponseti International. This is the meeting glimpse in 2013 when this registry and the PIA was created. When you start this registry, a message comes that this project will improve the treatment of thousands children born with the Clawfoot deformity in Pakistan each year, and the Clawfoot registry basically provides a base monitoring tool for progression, research, and improvement of Pakistan Clawfoot program. And these are the stakeholders, the supporters of this Pakistan Clawfoot Disability Prevention Program, the societies of Pakistan and Ponseti International and the governments. The Clawfoot a few words about the Pakistan Clawfoot Disability Prevention Program. It is aimed to prevent the development of disability amongst Clawfoot deformity with a sustainable national program, to establish a program that is integrated into the available healthcare services, functioning effectively for a foreseeable future, and using resource mobilized by the community and the government, and to develop a high quality Clawfoot care pathway with the health that helps in identification of Clawfoot patients, early age referral, correction with a uniform standard Ponseti methodology, and adherence to strict protocol of dressing, follow-up, and the monitoring. We utilize this Ponseti pyramid, which shows the different aspects of the resources which is utilized as national resources, local resources, clinical resources for identification of Clawfoot patients, referrals, corrections, and then follow-up with the high core values of the quality, equity, local ownership, and the sustainability of programs. Here, the champions of this program in Pakistan plays a vital role by strengthening the key features and core values of this pathway by providing leadership, energy, and directions. And then training to the healthcare professional, establishing the network of Clawfoot clinics, encouraging the patient record keeping in the ICR Pakistan registry, having held the Pakistan web conferences to facilitate education and communication, advocacy, education with the frontline health workers, parent groups, and the media, and development of the best practices guidelines. They also had played role engagement with the professional society, training institution, local health administrations, concerned municipal implementation of Clawfoot Disability Prevention Program of the Pakistan. Champions from Pakistan, Anis, Chinoy, and the Mansoor have played a pivotal role in development of these clinical guidelines, which were published in 2015. It is available on the Ponseti Publications and Information Center. These are the people which contributed in development of clinical guidelines in the Ponseti treatment. Then the champions all plays a vital role in the clinical site visits to collect the visit report, field notes, emails, and the quantitative inquiry, particularly for a scale-up of the program, to prepare a plan for health policymakers, social welfare department, children disability prevention program, and for the universities and teaching institutes to have the Clawfoot treatment methodology in the curriculum and execution of this Clawfoot prevention program in their clinics. These are a few words about how do we executed the Pakistan Clawfoot Disability Prevention Program, which basically we start in 2006 to 2020s. Pakistan had Clawfoot projected load of 7,500, which is mostly seems to be Clawfoot incidence is 1.1, 1.5 per live birth in Pakistan. We had a certain challenges to overcome during this implementation of this program. Mostly it was a superstitious belief among the low and middle socio-economic group. They were thinking that the delayed treatment, and they were advised the delayed treatment with surgery having immediate results lack of knowledge of poor long-term outcome of these extensive surgeries with the PMR, various conservative method and the Potter's method were being used, and some of the patients were also neglected to the adulthood, and then social taboos with adherence to the bracing. This is one of the example. Musculoskeletal deformities are being treated in the solar eclipse therapy. We also had a challenge to the accessibility and affordability to adhere with the long duration of treatment, then the travel distances from the houses to health centers, loss of working of the parents, and cost of initial and subsequent treatment. Also, the acceptance of early age referrals and concerns of parents for the infant physique, reliability for early treatment, and the heart rate conditions. Also, we had a lack of resources by the Ponseti providers and the Ponseti clinics and the uniform treatment methodologies. And over that, the competing obligations of the champions time to manage this program. We utilize this Ponseti pyramid, having the objective to achieve the early referrals, corrections, and the follow-up. And we use this in the 3 phases, which I will give you this as the next slide. Phase 1, that was from 2006 to 2012, we started the sensitization of orthopedic community, public and health policymakers to hold basic and the advanced live workshops that we conducted 46, and the media campaigns, live TV shows, and medical camps and meetings with the orbit official that the clubfoot treatment. Clubfoot is the preventable deformity from the disability cannot be developed if treated early stage. We also held in from 2012 to 2030 phase 2, we established the Ponseti Integral International Pakistan and had a grooming of the champions training by training and development of Ponseti faculty, resource mobilization, and thereby capacity building with a target of disability-free Pakistan by 2020. This is grooming of the champions and the Ponseti providers and the faculty at the University of Iowa in 2012 to 2014 and the University of the Sao Paulo at the Brussels. We also worked for the establishment of Clawfoot Clinics network at each district, university, and Archan hospital, involved the public and private health policymakers to support the early identification, early age referral, free of cost treatment, braces, and the follow-up, and also encouraging for the data feeding in international Clawfoot registry, which is used for the monitoring and the research further. This is the first meeting of the Ponseti group for this prevention program. We also had a mentorship opportunities, training, skill transformation program with the help of USAID, Ponseti International, Societies of the Pediatric Orthopedics and POA, and the Government of Pakistan Health Services, where we trained 46 consultants for 2 weeks continuous resident hand-on skill transformation training at the 4 centers by rotation. And during this 2 weeks, they have seen 350 cases and managed. And also the continuous training of the postgraduate trainee by 65 postgraduate trained at the Clawfoot clinics, 50 cases each week. So we trained 111 consultants, future consultant for this program. And this is the mentorship opportunities glimpse from the concern from the Iraq and from Afghanistan and Dubai also visited this program. So this is the evidence-based information. How could we manage this Clawfoot program? And this information is basically from the Clawfoot registry. And this shows the growth of Clawfoot clinic, increase in age referrals, decline in age, referral age, and publication as well, how much publication was published, and then a few points around the pointer. This graph shows the Clawfoot clinics. In 2013 only there was 9 clinics, and 2016 after at the start of mentorship opportunity there were 27 clinics, and thereafter till date we have 111 Clawfoot clinics with the Ponseti provider 146, and these providers has treated 25,000 patients till date. And out of this, there are active clinics who regularly feed data in registry are 36. And I am presenting from that 36 clinics data, 13,000 patients data, which shows very early age referral continuously increasing. It shows the 79% patients were below 1 year age, and 18% patients which were referred were the below 5 to 10 years, and only 2% patients is after 10 years age groups. This also shows a significant paradigm shift in the trend of publication on Clawfoot in last 30 years. Total 88 publications were published. 8 were before 50, up to the 2015, and last 15 years there was 80 publications when we started this program. This is 2006. And most of these publications are on the Ponseti methodology, that is 46. Last 15 years, 46 publications on the Ponseti procedure were there. This shows the distribution of the all last 30 years. And here is the Ponseti publications and the review articles, which is mostly 46, and almost all were published after 2006. This shows the growth of the Ponseti publications from 2006 onward. It shows 46 publications, and majority were 46 in the early age reference treatment, and very few on the PMR and guide. Points to pointer here are, we have the 110 Clawfoot clinics. Out of this, only 36 clinics regularly feed data in the ICR. And they show a significant dropout during earlier management. And at the tenotomy reached, when the tenotomy, there are 3% or 4% dropout, but total dropout at the bracing is 42%, where this shows a very low rate of the tenotomy of the patients. This is 33%, and range is from 14 to 78%. And here it shows the compliance of the rest. Basically, there is a compliance is always on the poor compliance, but this shows very good compliance only by 2%. But I can say the basic demographic data entered is basically proper, but the technical data has not been properly done. So this evidence-based information shows the success of sustainability of Pakistan Clawfoot Disability Program, that we had 110 clinics, consultant 146, 111 clinics, 146 consultants providing 25,000 patients has been treated in last 15 years. In the last, when we started the Clawfoot program after 2014, and they are 61% is less than 6 months group age referrals, and 95% are following the Ponseti methodology. This evidence-based information reveals the very early age referral to increasing access to the Ponseti Clawfoot clinic and establish smart Clawfoot clinic near their houses, and they are providing free of cost treatment, equity, and creed and community, and all the patients at the government hospital are providing free of cost treatment. The second impact of this ICR was the development of pediatric orthopedic registry, which we started from only on BDH. Initially, it was started in 2021 in September, and it is very active registry. 95 entries has been done in the last 3 months, and it is owned by the Pediatric Society. This is very password protected data, and there are 4 forms. It takes only 5 minutes to start to complete the form, and the follow-up form takes only 1 minute. Total data it shows about the Clawfoot. This is the data which you can see in an individual case reports, but you can retrieve your data, password protected data, all patients and the hospital data. So it was the success of basically Clawfoot registry, which helped us to create this pediatric orthopedic registry. This is the references from which I prepared this presentation, and thank you very much for your patience, and also thank you Indus Icon for this presentation.
Thank you, Professor. Thank you, Professor Anit Bhatti. So we'll moving towards the only left presentation of our first session from Professor Shafique Pirani. So what we are going to do is I'm going to play the slides, and Professor Shafique Pirani is going to present. Can you hear me, sir?
Yes, I can hear you. Thank you so much for dealing with this complication slide.
Okay.
Happy to go.
Okay, so I'm going to start sharing the slide.
Okay. Well, thank you, everybody. Thank you, Dr. Chinoy. Hello to all friends. Mansoor, Anis, Monica, Jose. It's my pleasure to present this talk on the principles of Ponseti management at ICON 2022. And congratulations to all of you for such a wonderful conference and for My thanks particularly to Dr. Ponseti for bringing this incredible treatment to the world for the benefits of children yet to be born. Next slide, please. The issue to start with diagnosis, and the point I wanted to make is really that the typical view is from the front, but please do look at the view from the side and the posterior medial aspect. So you can see the cavus, you can see the varus, look at it from the back and look at it from the side so you can see the equinus, because it takes the presence of cavus, adductus, varus, and equinus to make the diagnosis of clubfoot in a previously untreated child. Next slide, please. The question is, how do you assess clubfoot? Well, classification and scoring are both important. And what's the difference? Well, let's talk about diabetes. Everybody knows type 1 diabetes, type 2 diabetes, other types of diabetes. Diabetes is diagnosed and classified at the first visit. You have either type 1 or type 2. Whatever it is, it's done once, and it determines the treatment protocol and the prognosis. And then when next slide, please. When you come to the actual clinic day, it's not the type of diabetes that makes the difference. It's the blood sugar level. That's what actually guides what's going on. It's change in the blood sugar level reflects improvement, reflects relapse, and guides treatment that visit. Next slide, please. But it's actually the same in clubfoot, and we've heard about the 2015 guidelines. And the NIH guidelines developed by PIA actually divides clubfoot in 8 different types. And I just wanted to introduce this concept that each of these types of club feet has its own treatment protocol, its own prognosis. I won't say very much more because I'm sure others will refer to these when they talk about their various subjects. Next slide, please. Suffice to tell you, here's an example of 2 of the algorithms that have been created. Each of these types has its own algorithm of treatment. There's complex clubfoot and persistent clubfoot. Next slide, please. However, when we come to scoring, I think that's where the Piranha score can help. This is a score that many of you are familiar with 6 signs of clubfoot that change with clubfoot as the shape of the foot changes with Ponseti treatment. 3 hindfoot signs, 3 midfoot signs, each scored 0, half, or 1. And if you score every visit, just as if you were measuring the blood sugar in diabetes, using the Piranha score can change. It reflects the improvements or relapse, and it guides treatment at the particular visit when the score is done. Next slide, please. And you can actually, just like the blood sugar, you can graph it. And when you can graph it, you can plot the scores by week, and you can see that actually when you graph this on this stylized graph, you can see the treatments that are applied. You can see the tenotomy being done, the effect of tenotomy with improvement in the score, and the bracing being applied. And so this graph gives you a way to look at the entire story of a particular clubfoot on one piece of paper. Next slide, please. The terminology of bone movements is very confusing, and having been given the title, I thought I should just go over some of these basics. It's important, I think, to have a proper orientation so that because all the bones of the hindfoot move in all different directions in all different ways. So let's start out with a transverse plane of the clubfoot, and it was really Dr. Ponseti that drew attention to a proper terminology, and a credit to Dr. Ponseti even for this. If we, can you press, please? You start with the transverse plane, and there should be another, if you press it, there. And then you go to a vertical axis of rotation arising out of the transverse plane. Press, please. If the distal end of the bone moves away from the medial body plane, that is called abduction. And next, press, please. If the distal end of the bone moves towards the medial body plane, that's called adduction. I hope this is not superfluous. If it is, just let me know. I can move on. But I don't know the level of all the people that are watching, so I thought I'd go over its very basic information. Next slide, please. Similarly, now if you start with a sagittal plane, next slide, please, and then you move to a transverse axis of rotation arising out of the sagittal plane. Next slide, please. Press the button. If the distal end of the bone moves up, that's called extension. Press, please. If you move the distal end of the bone down, that's called flexion. Next slide, please. Now, if we start with the frontal plane, and then we have a longitudinal axis of rotation arising out of the frontal plane, press, please. If the plantar aspect of the bone moves away from the medial body plane, that's called eversion. And the other way, if the plantar aspect of the bone moves towards the medial body plane, that's called inversion. Once you get your hang around this, get your mind around this, it's then easy to understand that here we see ankle extension, press the button, please, and press the button, please, extension and flexion, press the button. And here the first ray, press the button, we see the first ray extension and first ray flexion. So some aspects of terminology which will help us understand the remainder of the talk. Next slide, please. So here we see the mid-tarsal joint, press the slide, but abduction. Here we see mid-tarsal joint adduction. Press the button, please. Press the button. Oh, doesn't matter. Here we see the subtalar joint. Looks very complicated. 3 articular facets, lots of ligaments. Its motion is confusing, but it can be simplified. Next slide, please. And this is actually a very important slide to understand. And this is one of the other genius contributions of Dr. Ponseti explaining this. The subtalar joint is complicated, but it can actually only move in one of 2 ways. Next slide. Next button. Push the button, please. It can move either into pronation, and if it moves into pronation, it actually abducts, extends, and everts. It's 3 motions all in one. Whereas if it supinates, it adducts, flexes, and inverts. And this is an important concept because in the club foot, the calcaneus is supinated. And when you want to correct it, you want to pronate it. And if you abduct it, then it will extend and evert. And that's one of the genius points that Dr. Ponseti made. How about some words about the pathology? Next button, please. There is a posterior medial retracting fibrosis. Dr. Ponseti described in his various dissections an abnormal thickening and shortening of the capsular ligaments, tendon sheaths, and tendons, posterior and medial to the ankle joint. And here you see diagrammatically the spring of the gastroc soleus contracture and the lines of the posterior medial retracting fibrosis. It's an important aspect because it's thought that this is the final common pathway that leads to, next slide, a tarsal misalignment. The mid-tarsal joints are misaligned, button please, into adduction, and the subtalar joint is, button please, supinated, button please, which means it's adducted, button, flexed, button, and inverted. Next slide, please. And it also results in tarsal-shaped deformations. Here you see the normal talus and navicular orientation. Button, please. Here is the tarsal-shaped deformation that Dr. Ponseti showed in his dissections. There is an increased talar neck medial inclination. Button, please. There is a wedge-shaped and a smaller head of the talus. Button, please. And there is a wedge-shaped lateral pole of the navicular. Button, please. And here we see this is the iconic dissection of Dr. Ponseti. Button, please. And it shows the wedge-shaped head of the talus. Button, please. The severe tibio-talar plantar flexion. Button, please. The medial talar neck inclination. Button, please. The severe medial displacement of the navicular. Button, please. The wedge-shaped navicular. Button, please. The medially displaced cuboid. Button, please. The wedge-shaped distal calcaneal articular surface. Button, please. And the adducted and inverted calcaneus. So this is a tall order. How do you correct all of these tarsal misalignments and tarsal malformations with a casting, manipulation and casting. Next slide, please. So here are some other points that Dr. Ponseti talked about. He said a well-conducted orthopedic treatment based on a sound understanding of the functional anatomy of the clubfoot, and I've already alluded to functional anatomy, which is really the subtalar joint, and on the biological response of young connective tissue and bone to changes in direction of mechanical stimuli, can gradually reduce or almost eliminate these deformities in most club feet. And what did I understand from this? And please, Jose or others, if you have a different interpretation, let me know. But this is what I understand, that in the first, you'll see the pathology in that cartoon on the left, that the navicular is displaced medially by the posterior medial retracting fibrosis, and it causes deformation of the tibionavicular joint. Now, the first manipulation, we abduct the foot, and it stretches the posterior medial retracting fibrosis. It laterally moves the navicular over the head of the talus, and it improves the shape of the tibionavicular joint. And we've shown this in our MRI studies. Next slide, please. What happens then in the first cast, if it's accurately applied in the position of maximum available correction, the manipulations will actually promote retracting fibrosis to lose its tensile strength. So that, next slide, when the cast is removed, there's an improvement, but for a short period of time. So that the interval between the removal of the first cast and the application of the next cast has to be short. Overnight, I think, allows the condition to relapse. Next slide, please. And what that leads to, next slide, please, is that in the second cast, the same thing applies and you get more improvement, such that after a number of casts, next slide, please, next button, there is, at the removal of the last cast, the tibionavicular joint is restored in its anatomy, the contractures are released, and you have a much better looking foot. Next slide, please. So we've shown this in some of our MRI studies. We did sequential MRIs. Here you can see at week 1, before casting, button please. Here you see the deformations that you see on Dr. Ponseti's iconic dissection. The severe medial displacement of the navicular, the wedge-shaped head of the talus, the increased medial talar neck inclination. Now, next button, please. You'll see next button, next button, next button. So these are actually my pictures of this club foot, and this was from 20 years ago. And you can see, next button, please. You can see how the anatomy of the talus has changed. That you can see the ossific nucleus hasn't really changed, but there's been a flow, for want of a better word, of the cartilaginous tissues around the ossific nucleus to rearrange itself into a better shape. The tibionavicular joint is reduced, the navicular joint is improved. And that's the genius of Dr. Ponseti's wisdom, because you cannot do this with surgery. It's just impossible. Next slide, please. And here we see the same thing from the plantar aspect. Button, please. You see the calcaneo cuboid joint, the medially tilted distal calcaneo articular surface, the medially displaced cuboid. Button, please. And here you see pictures of the same foot from the plantar aspect. You see the deformities correcting, the lateral border straightening out, the medial crease improving, until we get to week 5. Next button, please. Next button. And here you see the MRI, which shows that the cuboid is realigned. The distal calcaneal articular surface is now orthogonal to the long axis of the calcaneus. That cannot be done with surgery. It's totally brilliant. So how do I do this? This is what I found useful. And each one of us has our own techniques, but I thought I'd describe my own technique. I like to be seated. Everybody be seated on chairs. I'd like to have the baby on mother's lap, across mother's lap, breastfeeding if appropriate. And I believe I demonstrated that when I came to Karachi many years ago. There were patients that were the mothers that tolerated breastfeeding their children. It made everything much easier, because when the child is breastfeeding, the child relaxes, the manipulations become much easier. This is a team sport. You need a surgeon. Preferably the surgeon has to have white hair. The young assistant has black hair. The surgeon sits laterally. So this child who has a right clubfoot being treated is at the right breast, and the surgeon sits laterally, the assistant sits distally. Next slide. Next slide, please. The sequence of correction, remember what we're trying to do. I call it a sequence, but it's simultaneous. You supinate the forefoot to correct the cavus. You then abduct the foot under the talus to correct the adductus. And when you do that with counter pressure on the head of the talus, next slide, please, next button. What happens is, button, please. And we have a button. Go back, please. Go back. Go back, please. There. When you correct the adductus, okay, now push that button again, please. What happens is when you abduct the forefoot, it abducts the calcaneus. When you abduct the calcaneus, you automatically evert and extend the calcaneus, which corrects the varus and to some extent the equinus. That's a picture you have to have in your mind when you're manipulating the foot. Next slide, please. So this is what I like to do for my hand positions. The left button, please. The left hand stabilizes the hind foot. The thumb finds the talar head and stays on it. The index finger and the long finger on the medial malleolus. That's one way to do it, and then there's another way too, which I'll show you. And then the right hand stabilizes the forefoot. The long finger is under the first ray. The long finger under the first ray is what powers the correction of the cavus by elevating the first ray. The index finger medial to the first ray is what powers the abduction, and the thumb is on the first and second metatarsal heads to stabilize it. Next slide, please. Now, the first manipulation is you hold the foot with both hands. Then, with the right hand, long finger, you supinate the forefoot, and that corrects the cavus. And there's counter pressure on the head of the talus. That's the pink arrow. Next slide, please. Once you've done that, then you abduct the supinated foot. The pink arrow is on the head of the talus, and that is the actual sequence. That's what allows you then to get the foot into the proper position so that you can apply the first cast. Next slide, please. Now, if we're lucky, please start the movie. There's my long finger, my right thumb on the talar head. My long finger is under and what I'm doing here, if it's going a little fast, but I've supinated the foot. My right hand has come in, it's supinated the foot, and I've abducted, and there I've corrected the foot. That's the manipulation. The long finger came in, it supinated the forefoot, corrected the cavus, the index finger came in on the medial side. Let's try it again. Just press the button and see what happens. Anyway, it didn't transfer very well, but you can see the principles of it there. Next slide, please. So once you've got, that's the manipulation. This is the alternate technique. Rather than the index finger being on the medial malleolus of the left hand, the index finger can come behind the fibula, and the thumb is on the head of the talus. The right hand does the same thing, and whichever way you feel more comfortable, perhaps the index finger behind the fibula allows 2 points of stabilization on the lateral side. Next slide, please. Now, you've got to get your hands out the way because you can't put a cast on whilst the hand's there. So this is my preferred technique. Next button, please. My right thumb moves to replace the left thumb and stabilize the head of the talus. Then my left thumb moves from A to B, the purple, over the knee, and then it holds the knee, and that becomes my fulcrum. Next slide, please. And then my right thumb moves back over the forefoot. Could we press the button, please? Yeah. So you can see, oh, I'm going to show you my video. Okay, start the video rolling. Same thing here. You can see I've got the foot in the corrected position. If you roll the video, you'll see now my left thumb moving from its position on the first ray, and it replaces the right thumb. There you go. It then stabilizes the forefoot, and my right hand goes, my left hand goes up, my right thumb and fingers go down to support the foot. So I've tried to break this video down so you can see exactly how I do it. Different people do it in different ways. This is what works for me. Because I want to maintain the foot in the corrected position. I want to maintain that posterior medial retracting fibrosis stretched as I manipulate the foot, and particularly as I put the cast on, and then as I mold. Next slide, please. So now I've got the foot in the corrected position, and now the cast has to go on. So how does the cast go on? Hopefully we'll see in the next slide. The hands are out the way. Now, so far, it's only been me, the surgeon, who's been manipulating. Now, I'm still holding. Now, my hands are in the blue. Now, the assistant comes in and starts the padding and the casting process, initially a below knee. So on the left-hand side, you see 2 rolls of soft roll, tightly wrapped around the fingers on the toes, going over the surgeon's fingers, and then 3 rolls on the leg. Once those are on, and we stop at below knee, we do 4 layers of plaster Paris on the foot, including the surgeon's fingers, and then going up with 3 layers or 4 layers, whatever you require, depending on the quality of the plaster you have, and then you mold the plaster, you laminate the layers together. Next slide, please. Hopefully this will show. So here we see I'm holding the foot, and the assistant is actually doing what that diagram showed. Putting on the soft roll. Hopefully it'll move. Yeah, well, you're trying to get most of it, but you get the idea, okay? You got to put it on tight. You tear it off at the below knee. I'm holding the foot in the position of maximum correction. Now, next slide, please. Now the plaster goes on. This is one of the few things in orthopedics where you need 2 people who know exactly what they're doing. So I'm holding the foot in the position of maximum correction. Now, there's a 2-inch roll. It's 4 layers around the foot or around the forefoot, including over the surgeon's hands, fingers. And we keep going up, and you'll see, sorry about the quality. The quality was great when I sent it, so it must have been lost on the way. And we go, oh, much better. Okay. So now you see, you trim it off. Okay. You make a little roll of it so it's easy to take off. And then so I'm still holding, right? And the assistant is now laminating the layers together. And the assistant can also, if they know what they're doing, mold around the malleoli, medial malleoli, lateral malleoli. And this is all done with the baby breastfeeding, with a sheet over the mom's lap. Next slide, please. Now, we've got to do something. We've got to mold, okay? So why is this slide coming there? I guess they're showing the same thing. Right, so once you've got that first part on, you've got to then address these red spots, which are the dead spaces that lead to a cast slip. And in my experience, there's 3 places where there are dead spaces to get rid of. One is under in the arch of the foot, under the first metatarsal head. The other area of dead space is anterolateral to the ankle, and the third area of dead space is behind the Achilles tendon. And one has to mold. And how do you do that? Well, you can see this is the right club foot. And it's the left hand in the one-handed technique, the left hand in the one-handed technique that comes under the first metatarsal head, and the thumb sits there and pushes that dead space away. It doesn't move. The index finger of the left hand moves up and down over the anterolateral aspect of the talar head or the anterolateral ankle to smooth the area, but without resting in one place because you don't want to create a dent. And then the index finger of the opposite hand runs backwards and forwards above the heel to get rid of those red spots, the dead space behind the ankle, and that captures the heel and reduces the chance of a cast slip because the heel is captured. Next slide, please. So you should see now, this is where we were before. If you start the slide, you'll see my hand coming in. This is my hand coming in to take over from the assistant. Now there's my right index finger running backwards and forwards above the heel, and my thumb under the metatarsal head, creating that pressure. And you can't see my left index finger, but it's running up and down to create that mold over the anterolateral talar head. Next slide, please. Okay, we're going to see it again. Excellent. Thank you. Next slide. So once it's, oh, there's, if you go back, please, one slide. There should be another video there. Yeah, this one. So here the below knee cast is set, and I can see the smooth anterolateral talar head. Can you run the video? There's no dent. It's all smooth over the anterior aspect. I'm trying to show you there's the groove above the heel with my index finger, and that's captured the heel. I haven't touched the heel. And then on the plantar aspect of the foot, in the medial arch, you'll see it's flattened. Maybe you could just run it again, if it runs. Oh, doesn't matter. Then you gotta then extend the cast above the knee. Oh, you're gonna run it. Okay, good. Yeah, so the point I was trying to make here is the index finger of my right hand is showing you the groove above the heel. It's smooth over the anterolateral aspect of the ankle, and you can see the plantar aspect of the foot is very smooth too. So the arch, I've corrected the cavus in the first cast. So I've only put the below knee cast on. I don't put the whole cast on at one time because it's just too hard, especially if the baby's moving. I then proceed, if I'm happy with the below knee cast, next slide please, to extend the cast above knee. And it's simply an addition of some soft roll. I add a couple of slabs anteriorly, and then the cast goes all the way up to the groin, holding the knee at 90 degrees at least, more if in complicated club feet. Next slide, please. And then, as Monica was pointing out, addressing the toes, where you take the roof off the toes, the cast, but leave the plantar aspect on so that the toes can be well seen and monitored, and yet the platform prevents the development of knee flexion contractions. Next slide, please. So this is the same technique for the second and subsequent manipulations. Next slide. And you can see the second cast, the third cast, the fourth cast. And sometimes you get good progress. You can make, by 3 casts or 4 casts, you've reached a good position. Sometimes it takes 5 or 6 or 7 casts to reach a real good position where, next slide, please, cavus, adductus, and varus are all corrected. The heel is in nice valgus. The talar head is covered. Next slide. And then the last part, and this is necessary in probably 90% of cases, one needs to proceed with a percutaneous Achilles stenotomy to complete the correction of the equinus. Next slide, please. There's preparation that's required. Need to make sure the parents understand this is a safe outpatient procedure. It's under local anesthetic, and usually no painkillers are required, or rarely acetaminophen if there is discomfort. One does need to give them instructions regarding cast care because there can be a little bit of swelling if you're not careful. Next slide, please. And then the preparation that's required for the tenotomy itself. Next slide. The button, please. Yeah, this is what I use, sterile gloves, an insulin syringe or a TB syringe with a 25 gauge needle if available, because you only need to put a very little amount of local anesthetic in. A scalpel blade. In many countries I go to, all I have is a 15 blade, but if I have a choice, a beaver blade or a cataract blade is smaller, and it's easier actually. A little bit of prep solution and a little bit of gauze. Next slide, please. So the positioning, this is how I like to do it. I like to have the child at the end of the bed, with me at the end of the bed, the assistant on the ipsilateral side, holding the leg, and the parent, if the parent wants to be in the room, on the contralateral side. This is the key anatomy. You can see the transverse section at the level of the Achilles tendon up, away from its insertion. You need to be away from the calcaneal apophysis to avoid damage. Next button, please. You need to be aware of the posterior tibial artery and nerve. It's not that close to the Achilles tendon, but you don't need to go anywhere near it. The Achilles tendon, which is easily palpable, and the sural nerve and the lesser saphenous vein are on the lateral side, subject. Both the posterior tibial artery and nerve and the sural nerve and the lesser saphenous vein can be exposed to surgical damage if the scalpel wanders. So resist the wandering of the scalpel. Next slide, please. This is what I tell the residents. Next slide, button, please. So the assistant stabilizes the leg. The assistant's left hand, in this case, holds the knee extended. The assistant's right hand, in the gray, dorsiflexes the ankle, tensions the Achilles tendon, and externally rotates the leg to improve access. I prep the area. I put a little drape on it. I palpate the tendon. That's my yellow glove, index finger palpating the tendon above, a centimeter and a half above the calcaneal apophysis, and in my mind's eye, then I know where that tendon is. When I know where that tendon is, in my mind's eye, I put a little bit of freezing solution just medial to the area where I want to put my scalpel blade in. Next slide, please. Next slide, please. There. So now you need to aim the scalpel in the right direction. It needs to be inserted just medial to the tendon, directed slightly anteriorly into the soft tissue space, not into the tendon, but the soft tissue space anterior to the tendon, but avoiding the neurovascular bundles. Keep the blade parallel to the tendon to avoid injury. Once you're in, to a certain extent, rotate the blade so that the sharp edge of the tendon comes to the tendon. The sharp edge of the blade comes to the tendon, and then if you touch the tendon and slightly move it, you will transect the tendon. And you know you have transected the tendon if you experience a pop and a sudden increase in ankle dorsiflexion. If you don't experience a pop or a sudden increase in ankle dorsiflexion, the tenotomy is not complete, and you need to do it again. In a young infant, under 3 or 4 months of age, it's very usual to achieve 15 degrees of dorsiflexion when you do the tenotomy. Once you have 15 degrees of dorsiflexion, you put a little gauze dressing over the 2 millimeter incision. There's no need for stitches or anything. Just hold your finger there for a few minutes until hemostasis has been secured. Then I put a Band-Aid on. I actually put 3 Band-Aids on, one over the other. And then I put the last cast on, and the next button, please. And 3 weeks later, the cast can come off and the tendon is healed. Button, please. Button, please. Well, there's a button coming, but you'll come. But in the bottom one, yeah, you can see the bottom one. What I'm trying to say is that in older infants, you might get dorsiflexion, even though you have a sudden ankle extension and a pop, you might not get 15 degrees of dorsiflexion. And that's because usually there's some posterior capsular contracture that's persistent, that's resisting. And that can be improved with weekly cast changes and 2 or 3 cast changes, and you can reach your 15 degrees of dorsiflexion, apply the cast, And the same thing, the tendon is healed in 3 weeks. Next button, please. There you go. Button, please. So now you've obtained correction. It's vital to maintain correction. Next slide, please. This is the standard of care. Dr. Ponseti discovered this many, many years ago. He's always advocated for it. It's a rigid bar holding well-fitted shoes in abduction extension. 2 to 3 months, 23 hours a day, 4 to 5 years when sleeping. That's the prescription. It works. It's effective, but it's challenging. And there have been many other designs that have been developed. There's the articulating brace button, please. There's the KFO button, please. There's a fancy device with springs at ankle and subtalar joint. I don't find very many of these work. Next slide, please. In fact, this is a very interesting study for those who want to know more. Andy DeMeo is PhD. He did a magnificent modeling study, and the language isn't very easy to understand. But basically what he showed, that the only brace that works is the standard of care brace, which is the one that Dr. Ponseti advocates for, the one that PIA provides, the one that's provided by MD Orthopedics, the one that's provided, I think still, hopefully, by Markel. Now, this is an important slide. This slide compares the results of Ponseti treatment in the long term with surgical treatment. And when parents are faced with the challenges of brace, I show them this slide because this is published information. Very few things in medicine have 25-year, 30-year outcomes. Here we see Dr. Ponseti's treatment has 78% good and excellent outcomes if the treatment protocol is followed. Surgical treatment, good and excellent outcomes, 33%. There's another paper, the paper by Dobbs shows that those who had surgical treatment had 67% fair and poor outcomes, and these were treated at one of the best hospitals in the States. So now back to the Piranha Score graph. I use this because it helps me understand what's going on. It helps me plot on one piece of paper what's happening. What was the treatment that was done? And it also helps me understand if correction is progressing satisfactorily, is bracing indicated, etc., etc. Next slide, please. Here's an individual case. Next slide, please. Oh, before the individual case, go back one, please. These are the individual signs. I got some recent diagrams I thought I'd show you. Go back one slide. But okay, it doesn't matter. We'll go with hindfoot score signs. You got to look at the back of the ankle. If you've got multiple fine creases, that's a 0. That's normal. And on the right-hand side, you see a single indenting crease. That's a 1. That's a very severe posterior crease. And if it's halfway in between, it's a 0.5. Next slide, please. So all of these signs is 0, 0.5, and 1, and they can be summed. The hindfoot score sign, you can see that you're actually dorsiflexing the foot a little bit with a 0.1. And 0.2, you're going at the angle of the heel with your index finger or your thumb of your opposite hand. I'm trying to palpate for the calcaneal tuberosity. Now, if the calcaneal tuberosity is immediately palpable, that's a 0. That's the green. That means that the Achilles tendon is out to length. If it's only palpable with deep palpation, it means that it's tilted. It's tilted into plantar flexion, and that means there's some gastrocsoleus contracture present. If you can't feel it at all, it means the calcaneus is severely plantar flexed, and that's a severe gastrocsoleus contracture. Next slide, please. And this is a similar concept. You dorsiflex the foot. Oh, go back one, please. Okay, we'll go. Yeah, hindfoot score sign number 3, rigid equinus. You're pushing the forefoot up. I guess it doesn't want to do it. Doesn't matter. We'll go with a curved lateral border sign. This is the first of the midfoot score signs. And number 1, severe, is when you have a sort of a boomerang curve. It's quite curved, whereas a gentle curve is a 0.5 and a straight lateral border is a 1. Next slide, please. And this also shows you, we use the same pictures actually for a medial crease. Next slide, please. So a single deep crease is a 1, a single shallow crease is a 0.5, and a fine crease is a 0. Next slide, please. And then the last of the Mitford signs is the Taylor head sign. And I was just trying to put into diagrams what I understood Dr. Ponseti talking about, the head of the navicular sliding over the head of the talus. The thumb stabilizes the head of the talus from the lateral side. The other hand abducts the foot, and we try and see what's happening at the talonavicular joint. Now, if is in the green, the navicular reduces, the talar head becomes impalpable because the talar head is completely reduced by the navicular. In the orange, if the navicular reduces partly, and your examining thumb palpates both the navicular and the head of the talus, it's a 0.5. Whereas if your thumb is palpating the head of the talus, and by abducting the foot, you don't feel the navicular, that means there's a severe medial contracture present. That's the description of the Taylor head sign. Next slide, please. So, and we've tested all of these for inter-observer reliability and validity, and they are both. So they're useful to use. Next slide, please. Individual case. Here's a clubfoot before treatment. The midfoot score is 3, the hindfoot score is 3, the total score is 6. Next slide, please. And then we've done a number of casts, and now we've reached a point where the midfoot score is 0.5, the hindfoot score is 2, the total score is 2.5. The tenotomy is indicated in the situation. Next slide, please. And this is immediately after the tenotomy. Next slide. You'll see that here you can see my thumb over, holding a little dressing over the tenotomy site. The midfoot score is 0.5, the hindfoot score now is 0.5, and the total score is 1. And now you've got a fully corrected foot where you've monitored the progress of the clubfoot with a ruler or the Pirani score. Next slide, please. And I think I like to use the graph because when I have a graph like this, I can see that somebody put on a cast that was ineffective, that it wasn't holding the foot out maximally stretched. One is tempted to leave the cast and just come back next week and do it again, but it does extend the casting. If I have a situation like this where the cast isn't proper, I take it off and do it again or get somebody else to do it again. Next slide, please. Here you see this child did fine, but the child wasn't wearing a brace. We measured the clubfoot score. There was relapse occurring, so it helps you detect relapse too. Next slide, please. And here you see a cast, a prolonged casting phase. And this is what I sort of think about as a syndromic response, where with the best will in the world, it takes 8 or 9 casts before you reach the point of tenotomy. And this is that kind of foot where you say to yourself afterwards, I wonder if there's some kind of syndrome or collagen problem present. Anyway, that's my 30 minutes. Thank you for your attention. Thank you again for the invitation. And I'm sorry we had the audio problem, and I hope I was able to do justice. Thank you.
Thank you, Professor Pirani. I was enjoying moving the button. There was a very sorry.
You did great. Thank you.
There was slight delay in the relay.
No problem.
But it was utterly worth the wait that we were going through to listen to your presentation. Thank you so much. So we are already past our time. So we can have a panel discussion now, or maybe in the second half. I would like to know from the faculty if they want a panel discussion now, or we can go on with a break and then come back. Panel. ऑन कर दो सबको, ऑन कर दो, ऑन कर दो सबको. So can we take all the panel online? सब म्यूट है, सब म्यूट है.
Hey,
Hello.
Jose, how are you? Monica, how are you?
Hello.
Mansoor, nice to see you again.
Mansoor.
First of all, I would like to thank all of you, especially all the ones in the North American side, because of the very, very late session. I know, Monica, it's 3 a.m. with you. But I really enjoyed your talk a lot. Starting with Jose. Jose, thank you very much once again. It was a very, very nicely presented talk. As usual, very, very interesting to hear you speak. And then Shafique, I'm so sorry, my apologies for the technological hitch. We tried our best that it was as smoothly as we can. And then Mansoor, well, I won't comment on it at all. And Anis Bhai is a mentor here in Pakistan, and it is really encouraging that he is so enthusiastic and is so forward-looking and working very, very hard, especially with the registry, and now with that is the Pediatric Orthopedic Registry of Pakistan. So I'll ask Mansoor to start with some burning question, and then we'll go ahead.
Hello and assalamu alaikum. It is really unfortunate that because of COVID and other situations, we have to meet like this and after such a long time. And you people are my mentors. Whatever we have done, it is because of you guys. You sort of basically held my hand and led me and Professor Bhatti and basically the whole Pakistan program to where we are now, and we cannot repay you guys. Jose, that was a brilliant talk. It is so nice to see you guys again. But Jose, it is good to see that the whole world is basically following the path which Dr. Ponseti started, which you persevered in, and a lot of people, especially in third world countries, still a surgical treatment pays more money to the surgeon, so they prefer surgical treatment. But more and more surgeons are now following your line, understanding how good it is for the welfare of the patient. And I'm so glad that so many other countries are now starting to join us. I do have some questions for Shafique and Monica. Monica, I'm so sorry, it's 3 a.m. But it is such a brilliant talk which you gave. I have one question. We see a lot of these patients who are arthrodrypotic and who come to us late. Now, someone who's coming to us at 6 months or 1 year of age, we do cast them, and we've had reasonable to moderate amount of success just getting success by cast treatment. But I see some of them at my clinic who are 7, 8, even 10, 11 years old. And I have casted them with my own hands, and I get absolutely minimal response. And then we have to move to some sort of salvage surgical procedure. Do you see patients like this in your clinics now?
Hi, Mansoor. Hi, everyone.
I can't hear you. Ali?
Hi.
I can hear you, Monica.
Thank you, Shafique. Yes, we have those difficult patients as well. I think, Mansoor, the most important thing is for you to set a plan with the patient and the family. I mean, you will correct that feet, those feet, and you have to start to record your progresses. Okay, if you uh, if you are making progress, you're good. So you good to go on Ponseti. But if you stop for some reason, or you ask for help, that helps a lot here in the country where we have a net of doctors. So if you're having some trouble and you can reach somebody to help you out, it's a good idea. But if that doesn't move, just proceed into the regular tools that you have, okay? Tarsectomies is a good idea. As less resection you do, better for the patient. The main complaint of the 10-year follow-up of the arthros was that they could find shoes in the kids area. So the feet are very small, and they complain about it. So that's the main complaint. So it's not a sin jump from Ponseti to regular treatment with external fixation or whatever you have in your hand. But if you're stretching with the cast is a strong X-fix. So I believe the cast can do a lot of results. Sorry about the audio, something's going on. But I think this is like this. You put the best you can do on the Ponseti and you record your progresses because it's very important. And if so, it doesn't help, so you proceed on the regular treatment. You do some more soft tissue release, but you know that as much as you release, as much as contracts again. So it's a malignancy. So I think the tarsal resections are okay for one that's you stuck in the correction. So that's my tips for you.
Okay. How often do you see skin problems in a myelomeningocele patient?
Skin problems a lot,
Yeah.
like
Okay.
80%, and
Eighty
especially
percent.
especially in training patients. You cannot train the
Okay.
pressure. I mean, there's an article measuring the pressure of the students, and that's a big danger to teach students on those patients. You shouldn't not let them touch those kids unless you have a very good experience in idiopathic, because these
Okay.
graces occur and they're often. And those that baby that I showed that had a big purple legs, unfortunately, we don't see it very rarely because it's a training hospital. So if you're standing side by side still, you can have those kind of problems. So I think those are not fit for beginners. Those are advanced.
Okay. Thank
You
you.
know,
Manish
Mansoor,
bhai, it was very heartening to see how much work that has been done by you. A lot of the credit for the Clawfoot program in Pakistan does go to you, and we heartily acknowledge all the hard work that has been put in by you and your team. Um, and we may have started a little bit of the work here at Indus, but you carried it forward, and I can just applaud you for your hard work.
Mansoor and Monica, you have both of you are tackling this very difficult group of children with syndromic club feet, meningomallar club feet. You have large volumes, and
Yes.
I think it would be amazing if we could benefit from the lessons that you have learned. I don't see those cases in that
Okay.
age group, and you see them, and you're a reference center. You see, you're actually in a unique position to be able to um, put your mind to decoding what's going on, and what are the lessons you have learned, and what is it that you were able to show us or teach the rest of us. Both of you, you've got dozens. It sounds like you've got dozens of cases. So I
Uh,
encourage you to do that.
Shafique, if I just may make one comment,
I've I've been to many conferences, seen many presentations, read many books and videos, but your talk on the whole pathoanatomy of Clawfoot was brilliant, and I can say that even I got a big revision and how this whole process goes about, and it's just amazing how nicely presented it was.
Thank you. I've simply borrowed from what Dr. Ponseti has written. That's what I did.
How you presented it.
I didn't
How you
add
presented it.
anything else. I read and we tried to confirm what he has said, and that's all.
Our second session is going to be about the guidelines.
So we are on our
And I know
second
that
session.
I know that it's quite very late for you people, but I would like Jose to give a few comments on this occasion.
Well, first, thank you very much again for the invitation to participate in this meeting and to share with all of you. From my, it's too bad this COVID thing that for 2 years kept us all apart, and we haven't been able to get together, which I love to do with you. And I think, from my perspective and looking at the data that you are presenting, it is amazing what you're doing. And the truth is that, generations and generations from today, kids are going to have a treatment that is, going to make their lives wonderful. So it's really inspiring, and I really ask you to continue pushing a little bit more, so every child in Pakistan has the chance to be treated and have a normal life. And if there's anything we can do, I'm always happy to help.
We have not had a very, I would say, regular feedback from your side about the registry, the quality of entry, and things like that. So, are you actually, or somebody actually looking at them to give us quality audit feedback?
Sorry, there's a little bit of echo on my system. I don't know if for the others. Can you repeat the question?
I was saying that we have been regularly doing input into the Clawfoot registry. All the sorry, not the photo, but the photographs and the scoring. So, is anybody actually actively looking at those, and should we be getting any feedback as to the quality of correction thereof in the registry?
No, the reason is, these are medical records, and so only the people, your patients, everybody's patients, can be seen by you, because you are responsible. So in order to do a study is possible, there's two possibilities. One is, to get together and approve, a research project. I think with the number that you have, it will be amazing, because there's nobody that has the numbers that you have, thousands of patients over 10 years. The other possibility is to use aggregate data without identification, and I think that would be a way for, to also get information from, for all the people. There's nobody, nobody's looking at the cases or quality because of that issue that, is confidential information.
Yeah. So, but I think this is actually you have given some food for thought, because if we do that, the first option, which is sit together maybe on a Zoom or whatever, and actually look at it, so that we can really look clinically. We think that children are improving. We only this last December we 70 more children completed their 4 years. And in Karachi and 40 in Muzaffargarh. So that's 110 patients who completed 4 years this year. clinically the feet look all right, but from a audit point of view and from a statistic point of view, I think it would be nice to actually go back to the records and see them and see how we are actually doing.
Yeah, I think it would be it's a good idea. I think it's a a great teaching, and for quality improvement. I think because Pakistan has their own portal, then I think if you will get the consent from everybody, you have access to the information, and I think it will be very. I mean, we do in a selective basis when people want to be part of the Ponseti International, and they have to submit, the cases. We have a group that will look at. Dr. Pirani did it for many years, and others, Dalia and others that are looking at the cases, and really you can tell a lot from the pictures. Actually, you can learn a lot, and so I think that would be a great exercise for you. And
I'll tell you why, because the next presentation that I'm going to do, I picked up a couple of patients, and one had recorded the presentation and everything, and then I realized a few mistakes that I could identify there. And I'm pretty sure that people, like very experienced people like you, would definitely see them as well. And so I thought about it, and I said I'll discuss it here as well. Anis bhai, are you there?
Dr. Anis, can you turn on your mic? I've been trying to contact Professor Anis Bhatti, but I think he has some issue with his net.
He has issues in the internet. Last message from internet.
Yeah. Okay. So, sorry, Dr. Pirani is gone off net right now. Monica, would you want to add something before we close this session and start the next session?
Anis is back.
Anis bhai, would you like to give some comments now?
Actually, I could not hear what were the discussion in between because
Yes, there was some problem in the network.
उनकी तरफ होगी पूरी दुनिया बात कर रहे हैं तो
Okay, so we'll take Monica's comments in the meantime.
Well, thank you for the invitation. I really enjoyed this seminar. Learn a lot this evening or night or morning. And it's really nice to be with you again, and keep this work alive is a good thing. So thanks for being the Pakistan champions and so persevering with the work. It's so beautiful to see the data all together. So Bati, Chinoy, and Mansoor, all my accomplishments that you have really done this beautiful program with this huge number of babies, all in the registry, all the doctors connected. We know we have problems, but the beautiful of that is that we can make it. So it's a really inspiration for me, and to do the best we can for our children everywhere. So thanks for all the energy that you guys put on. Thank you.
Well, Dr. Pirani?
I'm flabbergasted. I'm so inspired by what you've done. You have turned the corner. Now there's no going back. For children who have regular club feet, which is the vast majority, you have solved the problem. The answer is there. You just have to implement. And as it takes time, but every year you get stronger and stronger and stronger. There's no going back. You have changed the course of the lives of so many children yet to be born in Pakistan. And I'm totally flabbergasted that you're able to do that. My sincere And noble congratulations. It really is wonderful. And it only happens because you guys are determined to do so. You're energetic. It's something I remember from meeting all of you guys, that you wear your heart on your sleeve.
As much as we know from Dubai.
Yeah, so I take my hat off, please. My
Thank
sincere
you.
congratulations, and thank you again for the opportunity to attend and learn.
Thank you very much. Dr. Bhatti, can you give us some closing remarks before we start the second session? Unfortunately, that's net is playing up with us. So I'll ask Ali to conclude this session so that we can start the next one, please.
Okay, so there's some connection issue with Professor Anis Bhatti's network. So we are already lost some time during discussion. So I would just go on ahead with the second session.